And I'm here to discuss firstly the translational results of the Valentino study. Just a brief recall to the study objective and design. Valentino investigated whether maintenance treatment with single-agent panitumumab may be non-inferior than 5-FU plus panitumumab following a 4-month induction with FOLFOX plus panitumumab in RAS wild-type metastatic colorectal cancer patients. The study actually enrolled 229 untreated and unresectable RAS wild-type metastatic colorectal cancer patients that were randomly allocated on 1-to-1 basis to either FOLFOX4 plus panitumumab up to 8 cycles, followed by maintenance treatment with 5-FU plus panitumumab until disease progression or unacceptable toxicity, or the same induction regimen followed by single-agent panitumumab. The first results of the study were presented at ASCO this year and were confirmed at ESMO with a longer follow-up time of about 18 months. The upper boundary of the 90% confidence interval was 1.85, so greater than the pre-specified non-inferiority margin of 1.515. So panitumumab was not non-inferior than 5-FU plus panitumumab in the maintenance setting. And actually, the 10 months progression-free survival rate was 49% in pan arm versus 59.9% in 5-FU plus pan arm. So pre-specified translational endpoint of the study was the evaluation of tissue biomarkers, in particular our previously published pressing panel, which groups together several uncommon, very uncommon primary resistance mechanisms to anti-GFR treatment beyond RAS and BRAF. So as in the initial pressing study, we performed several analyses, including silver in situ hybridization for HER2 and MET amplification detection, next generation sequencing for PI3 kinase, P10, AKT1 mutations, and also RAS mutations with the low fractional abundance that were missed by standard assessment at local centers. And also immunohistochemistry followed by RNA sequencing for detection of ALK, ROS1, and TRAC1, 2, 3, and RET fusions, and multiplex PCR for microsatellite instability. Actually, 189 patients with RAS and BRAF wild-type status were analyzed, and a quarter of them were found to be pressing positive in their tumors. Regarding the correlation with outcomes, patients with pressing positive tumors had a significantly shorter progression-free survival as compared to those with pressing negative ones. And median progression-free survival was 7.7 months versus 12.1 months with an hazard ratio of about 2 and a P of 0.0001. However, in the predictive analysis, the progression-free survival benefit of adding 5-FU to panitumumab in the maintenance setting was retained in patients with both pressing positive and negative tumors. Additionally, we must point out that the distribution of pressing panel alterations was similar in patients with left and right-sided primary tumors, and also that right-sided ones are most often primarily resistant to anti-GFR-based treatment, even in absence of pressing panel alterations, so we decided to perform a post-hoc combined analysis of both pressing panel and primary tumor location. And so we defined as resistant those patients with pressing positive tumors and or right-sided primary tumor location, and as sensitive those patients with left-sided primary tumor and pressing negative status. Resistant patients with this analysis were up to 1/3 of the total, And in resistant patients, median progression-free survival was again shorter than those with sensitive tumors, and median PFS in fact was 8.1 months versus 13.2 months, with the same as a ratio of about 2, but a greater population, and the same statistically significant p-value. Again, in the predictive analysis, the benefit of adding 5-FU was maintained in both resistant and sensitive tumors. So there is a lot of room and space to improve the selection of patients that may be eligible for anti-EGFR based treatment beyond RAS and BRAF. Of course, this study cannot give an answer on the predictive utility of this panel, since panitumumab was given in both maintenance arms, but actually this study goes in the same direction of improving molecular selection, a term that we have called hyper-selection of patients for validation by future prospective trials.